Okay. And so just for background, my name is Dr. Fabiola Balmir. I am a reproductive endocrinologist and fertility specialist. I am board certified in both obstetrics and gynecology, so I did used to deliver babies. I'm also board certified in reproductive endocrinology and fertility. Okay. I'm located in Minnesota, more specifically Minneapolis at our Kindbody location. Happy to see you anytime. I'm a part of the Kindbody family. Kindbody is phenomenal. That's all I can say, like, to start. I came from a academic practice prior to being here, where I was a director of medical education and kind of community outreach, reaching out to physicians, local physicians, gynecologists, internists in the community, teaching them about fertility, medication starts that they could do for their patients before resorting to IVF. So I'm very familiar with kind of just discussing these talking points for how fertility works from basically any level. My passion is teaching. And when I came to Kindbody, I found a group of people who felt the same. We're very much interested in teaching patients and making decisions with patients together. That was my goal, right? It's a partnership when we partner with patients in creating plans. You know, I still remember the days of when we practiced medicine and a physician would tell you, this is your plan, please go out and do it. And you have to act out this plan, not really even understanding the medications you were on or how the plan was supposed to work. How are you supposed to be successful in enacting that plan? And I still encountered that in my parents' health, where going to their healthcare appointments and they say, I'm not really sure why they're giving me this medication. I mean, that's still prevalent. We still see that. But at Kindbody, we really seek to give patients kind of the option of how they choose to build their families, how they choose to approach their care. And that's my goal. And so we offer amazing services. For the fertility end, we also offer consultations for all persons, right? We offer virtual consultations. We specialize in virtual consultations. We'll see you anywhere in the country. We have providers who are licensed in all 50 states in the United States. Myself, I'm in the process of pursuing multiple medical licenses around the surrounding states of Minnesota. I've still maintained my Pennsylvania license. We specialize in egg and sperm freezing for those of us that are considering our future fertility, right? We've heard about egg freezing if we're not yet ready to conceive and we know we want to have this option on the horizon for ourselves. Same with sperm freezing, right? Sperm freezing has so many options available to us, including, prior to chemotherapy type treatments or treatments that can be toxic to eggs or sperm, where you lose your supply, were you to undergo those treatments that you need for your general health. We also offer that as an option if we're about to undergo gender reassignment, right? And so we can offer the egg or sperm freezing in those instances so that you can continue to pursue your own personal goals. Embryo freezing is a wonderful option. I had a series of patients that were just not ready to begin growing their families yet, and they wanted to be able to just hold aside a set of embryos that they knew would be aged just as they were in that moment, that they could then utilize maybe 5 years down the line. We have various reasons for doing that. We, of course, offer intrauterine insemination. That's the process of taking the sperm, cleansing it by getting rid of the dead sperm, the non-moving sperm, any of those abnormal sperm, concentrating to the perfect amount of sperm to deposit inside of a uterus so that it can make its way out to the fallopian tubes. That's your intrauterine insemination, more effective than the intravaginal inseminations and the cervical inseminations. And of course, we have in vitro fertilization or IVF, with just different ways of performing this and how we cater to patients to perform this. You know, we've catered to patients who need specific types of cycles from certain specific medical standpoints, whether you have one ovary or whether you've had a hysterectomy, right? We specialize in being able to obtain those eggs for you through in vitro fertilization, through egg retrieval, and fertilize those eggs to create those embryos for you. We can also assist with donor egg and donor sperm. This is the fantastic thing about Kindbody. We actually have an egg bank associated with us where we have egg donors that we hand pick, and we're able to cryopreserve or freeze their eggs. And you can go through a profile of these donors to find out characteristics that may suit your own, that you'd like to utilize for fertilization and creation of your own embryos, right? We can do that. We can also assist you with finding donor sperm, lots of donor sperm options. We have the option of using donor sperm from a known donor. And if you don't have a donor that you know, which is perfectly fine, and more often than not, we don't, we can help you in finding that frozen sperm donor and assist that process of getting those vials of sperm for you to be able to use for the inseminations or in vitro cycle. We also have the ability to perform genetic testing for you. And there's a variety of genetic tests we offer. Everything from testing for silent carrier diseases, like silent diseases, we've talked about that, diseases such as cystic fibrosis, we can test you for this and see if you carry these genes. Testing that we offer for you as a couple, where maybe you have a family history of a certain genetic disorder, but you're not sure what it is, we can screen you for this. And if you as a couple, both of you, devoting egg and sperm, are found to be carriers of this disorder, we can do IVF, create embryos, and select out those embryos with that particular catastrophic genetic disorder so that you can go on and have a healthy pregnancy, healthy pregnancy, and that reassurance, right? We can also offer that. Fertility testing that we have can be done in office. We can also offer you referral sheets to get it done at a provider. And you can also have at-home insemination test or semen tests if that's something that you need. We have a variety of offerings. I urge you to contact your local Kindbody office if you have any interest in finding out more about these offerings, right? The counseling and support with Kindbody is extraordinarily strong. This is by far the strongest I've seen from any other fertility center, kind of the holistic view of the person coming before you, asking for help and getting pregnant, right? It's not just about helping you get pregnant, right? It's the whole view that goes with that. And it's that support for you if you're LGBTQ+, right? It's that support for you if you need a surrogate, right? If you need a gestational carrier, we actually have an agency that we're connected with within us that we can help you get that gestational carrier that can either carry your eggs from the sperm from you as a couple or embryos for you as you've acquired from a bank outside of us or that you've acquired from a known person, right? We're happy to have these services extended out to the community, right? We also care about your general wellness. Fertility is a journey and it is a rocky road. I have suffered from infertility. My colleagues have suffered from infertility. My family members have watched suffer through infertility, right? And that's what it is. Why does it have to be suffer through infertility, right? It may be something that we may have to go through, but it doesn't have to be that we suffer as we go through it, right? We can find balance as we go through this journey, right? And so we have offerings for mental health that can focus on specific things that we tend to encounter, such as pregnancy loss, or just the general feeling of if I go to one more baby shower for a friend, I think I'm going to lose it, feeling I had. Pregnancy and postpartum kind of depression feelings that come with that as well. We have resources that we offer for patients, and we're well connected in our communities for those offerings as well. Okay. So getting started now, we're going into our Fertility 101 discussion and how do we get pregnant in the first place? And we need to talk about kind of those basic building blocks for us. And those basic building blocks will include sperm, eggs, and a uterus. I know it sounds really simple, but we need to talk about how all of those elements come together and how we begin evaluating when we're not getting pregnant after trying, right? The most important factor to consider with sperm, eggs, and uterus, most important is age. We are born with all of the eggs we're ever going to have for the rest of our lives. I can take that next slide, Michelle. Every day, our egg supply is depleting and the quality of those eggs are going down, right? So imagine this, I'll say it one more time, right? Because I've had to say this for my friends and family as well. I'm in that age group where we have these conversations all the time. So we are born with all of the eggs we are ever going to have for the rest of our lives for those of us with ovaries. We're born with approximately anywhere between 300,000 to my textbooks had stated 400,000 eggs. And every day that supply of eggs is slowly depleting and the quality of those eggs are going down. And every month we're losing a certain amount of eggs, even though we're only ovulating just one of those eggs, right? Next slide. By the time we're 40 years old, about 80% of our egg supply is abnormal. Imagine that, right? The age of 40, about 80% of our egg supply is considered not normal, meaning eggs that will fertilize with sperm will have a higher likelihood of being embryos that don't give us implantation or may have certain genetic abnormalities, or may give us a miscarriage, right? And we know this through obstetrical data, where we see older women with more miscarriages. We see older women with a greater risk of having genetic abnormalities to their children. It's just what we know. And we were able to extrapolate that information further from IVF data, where we created embryos for women across a large span of age groups and found that in that age group of 40, it took about, 10 embryos to have one genetically balanced embryo. That's what one study stated, right? So at 35 years old, we start to become a little bit more aware and a little bit more assertive for those of us that want to begin expanding our families. Because if you imagine at 35, it takes you maybe up to a year to get pregnant, let's just say. And you're pregnant at age 36, you have your first child around age 37. It takes you about 2 years to recover from that, because honestly, there's a toddler running around and you can't even imagine being pregnant at that moment. It takes you that long to actually forget I was pregnant. And you're ready for the next round. And then you may suffer that extra period of time of taking you to get pregnant again. And you're getting closer and closer towards age 40, which makes it even more difficult for you to get pregnant, right? And so it can reduce our family numbers because of the time frame we were ready to start. So this is where we start becoming more cognizant of what is our fertility. When should we start to intervene? When should we start to learn about this? And I say, there's no time like the present. In your 20s and your 30s, learn about it as soon as possible. Next slide. So the important factor here is that quality and quantity of eggs matter, right? A moderate quantity of eggs in a 44-year-old woman is different than a small quantity of eggs in a 25-year-old woman, right? The quality with age is always going to be significantly more important than the quantity, because there's a lot we can do with quality. And as we get older, we tend to compensate for the quality with quantity. So we need more eggs to make up for the quality effects from age, right? Again, we talked about, just as this slide states, the more poor the egg quality, the more risk we have for miscarriage or just not becoming pregnant at all. And there is no specific test that we have for egg quality. I should also say that. And this, I like this slide also because it's true. There is no age at which we're too old or too young to learn about fertility. I say as soon as there's an interest, let's learn about it, right? That's kind of my mom's philosophy too. Okay, next slide. So let's talk about kind of our fertility and how does that work and how are you supposed to time your cycles if you are trying to get pregnant? How does that even happen, right? How are these people using their apps? Should you only use it? Well, for starters, apps don't have the ability to test your serum levels, like the actual blood levels of urine, the blood levels of estrogen and progesterone, kind of those important hormones that we need to test to figure out where you are in your cycle. And these urine test kits can have certain inaccuracies associated with it because it's not as direct as the serum blood test. But for the most part, for a woman who has a regular monthly cycle, anywhere between 28 to 30 days, can expect her most fertile days to be roughly around cycle day 10 to 14 if your cycles are regular, right? Next slide. We can assess for your fertility status using our own modalities, specifically looking at an ultrasound that evaluates your ovaries. And we can also test blood tests called AMH or anti-Müllerian hormone. So for the ultrasound, we utilize a wand, a slender wand that's placed inside the vagina and allows us on ultrasound to see your uterus and your ovaries. And ultrasound that's pelvic, that's the vaginal ultrasound, is the most accurate way to assess your follicles, your ovaries, and your uterus. It will give us the best understanding of any underlying infertility issues you have that may be structural. That ultrasound, as it looks at your ovary, can determine how many cysts you have in place. Now you think cysts, oh, this is bad, but not all cysts are bad. Some cysts are follicles. Follicles are natural or physiologic cysts in your ovary containing eggs. All follicles are cysts, not all cysts are follicles. So with these follicles and their microscopic eggs, if we're at the beginning part of your cycle and we do a baseline count of those follicles, we can have an idea of how many potential eggs you could produce in an IVF cycle, potentially. The AMH blood test is actually a hormone that comes out of your follicles directly and can tell us if you have a high egg reserve, low egg reserve, or moderate, right? If it's an average amount. So combining those two pieces of information gives us an overall idea of what is your egg reserve? What does that fertility look like? And that's one of the first evaluations we perform. Next slide. Again, I'm totally sorry for all the dog barking. 2 dogs, very anxious that I'm in a room. Okay, so what do we learn from these results? Testing, again, we talked about the quantity of eggs. Now, I'm not specifically from this testing going to learn that you have 100 eggs or 72 eggs remaining. I won't be able to learn that. I'll be able to tell if we just have a high amount of eggs, a low amount of eggs, or a moderate amount of eggs. But keep in mind, we have to factor in these results as a big picture. One of the first things I ever learned in medical school was that you never just take a number at its value or one specific assessment as being diagnostic for the whole patient, right? We always take into account various factors that come into play with this number. So I can get an AMH level that's in a moderate range, but if I look on ultrasound, I see very few eggs, I'll question the AMH level, right? And somewhere in the middle there lies the truth. We want all of those findings to sort of align with one another. And again, if I have a high AMH level, high egg reserve in a woman who's well into her 40s, right, it still doesn't change the fact that the quality of those eggs is likely lower, which is normal in our age group, right? So always remember, it depends on the age as we take into account all of these numbers. And the important factor here that I want to add before we change the slide, Michelle, I want to add this. It's important that if your AMH is low, that you consider treatment sooner or fertility evaluation sooner, because AMH and egg reserve will get lower with time. And what happens eventually is that the AMH or your egg reserve may be so low that we may not be able to intervene with any medications that will make any more of a difference than your natural cycle, meaning many of our medications help you to release more than one egg or grow more than one egg and follicle. If the AMH is so low that you can't respond to medication, our medications won't let you produce any more than one follicle, which you would naturally do. So keep that in mind. We'll come back to this concept again. Next slide. Okay. Sperm health, super duper important. Up to 50% of infertility cases can be due to sperm. Abnormal sperm numbers, their shapes, abnormal sperm movement. And this can be secondary to a number of factors, including perhaps genetic, perhaps an exposure that can include marijuana, smoking, excessive heat at the workplace. All of these can be factors contributing to abnormal sperm. And so abnormal sperm can include big heads, 2 tails, 1 head, 2 tails. I'm sorry, 2 heads, 1 tail, that's what I want to say. Pinpoint head. All of these are different types of sperm abnormalities we can see. To test the sperm, we perform what's called a semen analysis. A semen analysis is a test done by persons with testicles where they abstain from ejaculation for 2 up to 5 days to maintain that specimen. and then produce a specimen either at home to bring to us to the office, or produce a specimen in our office in a designated space. And we then take that specimen and analyze it under a microscope and do testing to determine if this is an adequate specimen. Did you know that a normal amount concentration for sperm in one droplet is 15 million sperm, 15 million, right? We want to see numbers at 15 million or above. Okay, next slide. All right, the next portion of our evaluation includes evaluating the uterus and the fallopian tubes. I love this test. I personally love to perform this. So we talked about before placing the wand in the uterus inside the vagina to better see the uterus. Now this wand only allows us for a certain view of the uterus where we're seeing the uterus close, but the uterus has a cavity. And so oftentimes what could be cause of infertility can be a growth in the cavity, whether that's a polyp growth in the cavity or a fibroid that's in the cavity. So I think everybody can see my cursor here. Let's look at these different types of ultrasounds. This first ultrasound you see over here labeled A is a transvaginal ultrasound where we're looking at the side of the uterus, like a profile view of the uterus. And the black area that you're seeing is the sterile saline solution that's placed into the cavity to distend the cavity and separate the walls. We're looking here to find any lumps or bumps in that wall that could be obstructing an embryo potentially implanting into the uterus. And so this cavity is totally clear. Again, black means just clear fluid, and that's normal. The other image is still the uterus, but it's as if you're looking at the uterus right in front of me in a triangle, right? And it allows us, this is called a three-dimensional ultrasound that looks at the entire muscle in kind of that cross-section to see if there are really no lumps or bumps in the cavity. And both of these are happy landing grounds for the baby. These are perfectly normal. So our office will perform for you, as any kind body office, saline ultrasounds, as we call this. And what we would do in the saline ultrasound is also do what's called a corresponding bubble study. That's where we add a bit of air to the fluid in the cavity. And while watching under ultrasound, we can see that air as bubbles dissipate through your fallopian tubes. Now, this test can also be done as a hysterosalpingogram. You may have heard your friends talk about this before. Hysterosalpingogram is simply a dye study, an X-ray that's performed of the uterus and fallopian tubes. It's typically done in a radiologist's office. It's done with an opaque dye. It's usually iodine, water-based to reduce allergies. That dye is placed into the uterus and we can watch it dissipating through the fallopian tubes. The advantage of doing a hysterosalpingogram is that we don't have to worry about those soft tissues like the bowel getting in the way of our visualization as it would on the ultrasound. Bowel shows up on the ultrasound, it does not show up on the X-ray. So this may be an option for those of us with higher BMIs where it might be more difficult to appreciate kind of the uterine contour and fallopian tubes on an ultrasound, right? Body mass can sometimes affect that. All right, next slide. So what other factors affect fertility that we need to be aware of, and some notes that we should make for ourselves? Well, diet and lifestyle, no doubt, affect our fertility, right? Is there a specific fertility diet? I get this question a lot. There is not. You know, I don't have one diet book. I mean, I'd have a fortune, right? If I knew the exact diet and went and lined my walls with it, it'd be wonderful. But there's no specific diet for our fertility, right? We know that we want to reduce kind of those processed foods just in general. We know we want to reduce kind of our exposure to toxins just in general. What do I mean by that? Not heating up your plastic in the microwave, keeping your plastic out of the dishwasher where it also gets hot, right? Thinking about those types of things and staying away from more of those heavily processed foods and going more to those fresh fruits and vegetables. Kind of that's the diet you want to maintain in pregnancy. It is the diet that you want to maintain as you optimize your fertility. We also want to think about lifestyle choices where we have a reduction, I didn't say elimination of alcohol, just reduction, reduce it, reduce it, reduce it. Elimination of tobacco use. I would also say elimination of any marijuana use. I know that's becoming more and more common. And also elimination of any kind of recreational drugs we might also be utilizing. We definitely don't want that either, because that can compromise our fertility and also general health. And there are also factors that we don't want to utilize in pregnancy. Those are kind of the healthy lifestyles, and exercise maintenance is super important. We'll always watch out for extremes, right? Extremes in exercise, where we're losing significant amounts of weight so that our periods are no longer regular. This is bad. But having that moderation in exercise, moderation in diet, also very good. Family history can, of course, impact fertility. One of the first questions I'll ask patients is, does anybody in your family have any fertility issues? Do you have a brother or sister that's had multiple miscarriages? That could be a genetic disorder that's passed down that we can screen early for. Did your mom have multiple miscarriages? Did your mom have a hysterectomy at an early age? These are significant factors for our family history that we want to be very attentive to. And mental health, right? I've heard this often, where does stress impact my ability to get pregnant? It can. It can, right? And it's not just a matter of one of our aunts or cousins telling us that, you know what, if you just relax, you'll get pregnant. I'm not talking about that. That's actually terrible to hear every time. I'm talking more so about the type of stress that's so bad that it can literally stop your menstrual cycles, right? Or affect you so bad that your diet changes, or that you have difficulty sleeping. And now your general kind of circadian rhythm has been affected by this. Right? It's important to maintain good mental health, good sleep habits, eating habits, relationships with our friends and families as we go throughout this process, and seek out help when we need it, right? I think it's an excellent opportunity for us to use mental health professionals in our journey, and not so much talk off our girlfriend's ear or our partner's ear. I think it's more important for us to kind of seek those professionals that know what advice to give us in cases like this. Next slide. Okay. So infertility is defined as the inability to get or stay pregnant, right? The category of recurrent pregnancy loss falls under this after about 1 year of trying. Now, I'd say it's 1 year of trying if you're age less than 35. If you're age greater than 35, it's about after 6 months of trying, and you should consider getting a fertility evaluation. I'm going to put a red light on that for 1 second. I ask you, if you have questions, even before you started trying to get pregnant and you're ready to get pregnant or grow your family, right? Get your fertility evaluation. Go to a fertility specialist, go see a reproductive endocrinologist, get those questions answered upfront. Don't wait to try for like 6 months or 3 months before you move on because you haven't met a necessary diagnostic criteria, right? I'm more than happy to see patients who have just started to get pregnant, and we're talking about how to optimize your natural fertility, right? We're having those options available. And even just that discussion can significantly reduce our stress levels as we go on to that next step. Okay, next slide. All right, so what can you do in terms of initial consultation? Well, one-on-one discussion, we just discussed with fertility specialists, just right off the bat. You don't have to wait, right? You don't have to wait for 3 months before someone will hear you or understand the anxiety that this is giving you, right? We can immediately start to optimize right off the bat. We could also have in that discussion your medical history. Of course, a full history is taken, family planning goals. How do you choose to grow your family? Who's going to be carrying the baby, right? Where are we getting the sperm source? Where are we getting the egg source? Helping you kind of shell out that plan. We have all of those resources available, and it's a personalized plan. I think this is key. So I think one of the drawbacks, even in my own healthcare, was being placed into like cookie cutter options, right? This doesn't fit me. It doesn't fit me. It doesn't fit my family. And so we really want to know what fits you. How do you envision this happening, right? How can we work together, partner together to get you to this goal, right? Not every cycle plan is a fit for every single patient. That may not be part of your goals. It may not be part of your ethics. It may not be part of how you imagine this, and you're not there mentally to do this plan or execute it. Okay? So we have to be cognizant of that and find that plan that works for you. Next slide. Okay. So I think this is an excellent slide. It hits home with me really well, because we imagine, for at least my colleagues and myself, I do remember having this conversation with them and my friends. You know, we always think that pregnancy is just something that happens when you think about it and you're planning out your life. You're in high school. I think, oh, this is how I imagine my family. This is how it's going to happen. I'm going to be this age when everything happens. It's just not like that. And you get to this part where you're planning out how you're going to get pregnant, and it's just not happening. It's not happening the way you imagined. It's not happening like this. It's not happening the way like your mom told you it would if you weren't careful. Forgive me, I've heard that story before. It's a circuitous road for many of us. More people than they like to admit it's that way. Be open to all the different ways to expanding your family, and you can be successful. That would be wherever you go. You have plenty of options before you. And honestly, any of these options can be discussed at any time, right? You could be, I'm going to give you examples of persons I know, friends and family, right? Who've had lots of conversations, they're very vocal about this, they've got their own social media pages. You could be my 41-year-old great friend who is very much single, heterosexual, and very much interested in having children in the next year, who did multiple egg freezing rounds to get to 19 eggs. She's going to start growing her family. You could be my 32-year-old friend who did multiple cycles of IVF to get a total of 15 eggs and then decided, you know what, actually, I don't think I want to do this kid route after all, but I'm happy I had the option. Still works. You could do embryo freezing, where I have friends who are in a current difficult life situation and they're not yet ready to have children, but they know that kind of their fertility is starting to wane. And it's going to be significantly more difficult for them. And they're already with their life partner and they've created embryos, right? You can also just actively start a fertility treatment anytime, right? And that doesn't mean you have to wait. You don't wait. You don't have to go through multiple cycles of in vitro uterine insemination to ultimately do IVF. You can start IVF off the bat with the right indications and with proper evaluation. And you'd be surprised how many people meet that criteria that they can just proceed. Same thing for insemination. If you've never tried to get pregnant before, should I even try insemination right off the bat? Maybe that's a proper choice for you and your family. You know, access to donor egg and donor sperm, gestational carriers, we can do that right off the bat and make this happen pretty quickly for you. Usually for my patients, I quote from start time to finish time and doing a cycle of IVF, a 2-month turnaround to pregnancy if everything goes according to plan. That's one of the best things I can tell them. Next slide. So egg freezing, what is that? You've heard about it, you kind of know about it. I don't really think there are a lot of TV shows that discuss egg freezing. There's not a Netflix on it yet. Netflix mainly does kind of these IVF cases, but I think egg freezing is really interesting. I'd love to see a Netflix movie on that. It's the process by which we can extract the eggs that are available for that month from your ovary and freeze them for you for later use. Next slide. Now, the interesting thing about egg freezing is that it's not for everyone, right? It's for those of us that choose to preserve our fertility. We're not yet ready to fertilize those eggs. Couple considerations, or I should say more than a couple, quite a few considerations go into play. First factor, age. I know, I never get tired of talking about it. And it's the discussion I had with my REI too, come on. So age is always going to be a factor for the success of your egg freezing, of course. The closer we are towards age 40 or past age 40, the more eggs we need to freeze to have that one successful egg meet with the sperm to lead to an embryo. We have to keep that in mind. How many kids are ideal in your imagination for your family? Like what you imagine for your family, right? You have to have that kind of number in mind as you pursue egg freezing, because we're going to quote you kind of a number based on your egg reserve, of how many retrievals it may take for you to achieve the number of cohort of eggs that will most likely give you that outcome. You have to know that. How old do you want to be when you have your first child? These are hard questions. You know, these weren't questions I was necessarily thinking about in my 20s because I wasn't there yet, but some of us are. And how old do you want to be when you have your last child? I think these are all kind of important questions to ask ourselves as we go into that egg freezing phase. And so the thing to keep in mind regarding egg freezing and how we would extract those eggs, I get the big concern that if you do egg freezing, you're going to lose a portion of your eggs, you're going to end up into menopause sooner, as if we're using up that supply of eggs, which is not the case. If you think of your ovary as having a certain amount of eggs every month available, a group of them are dying off and only one is being released for that ovulation. In IVF or egg freezing or any kind of cycle where we're harvesting, our goal is to recruit those eggs before they have a chance to die off and save them for you. You're going to lose them anyway that month is kind of the concept I put in people's minds as they pursue this, right? These are eggs that you otherwise would not have utilized. And the next month, there's going to be a whole other cohort of eggs. And your AMH will determine how many eggs we have available each month. Next slide, excuse me. Okay. So with fertility care, we basically give you hormone injections of the same hormone your brain makes. So let's take back that step. How's that working? Well, every month our brain sends out a hormone signal of FSH, follicle stimulating hormone, and luteinizing hormone to our ovary. The ovary in turn responds by growing one follicle, an egg, as the dominant egg and follicle. And as this hormone signal gets higher and higher, that follicle gets bigger and bigger and bigger until eventually she's so large, she ruptures open and releases that egg into your fallopian tube. The egg awaits in the fallopian tube until it meets sperm or there's no sperm that's there, it dissolves, hormone levels drop, and you get menses or release of that lining from your uterus. In IVF, we're giving you that FSH and a form of the luteinizing hormone to stimulate your ovaries. Instead of growing that one egg and follicle, I want 10. Give me 10. And everybody will respond differently. But on average, 10 follicles and eggs growing at the same time with these injections. Next slide. So these hormone injections can be anywhere between 10 days to 12 days of hormone stimulation. It may be greater. We follow your body's cues, the cues of your ovaries. For some of us, the stimulation can be 20 days. I had a patient that needed a 20-day stimulation because that's how long it took for her to respond to the medication. Follow those cues. And what we're looking for is going back to that ultrasound and those follicles. We're looking for specific sizes of the follicles to be at good sizes that indicate to us they have mature eggs or eggs that are capable of being fertilized with the sperm that are ready for harvest or retrieval. So we determine that by the growth of those follicles, and we try to get that growth as synchronous as possible in both ovaries so that they're all a good size at the same time. Not always possible, but we do our best to try to get you there. Next slide. And so throughout the course of these hormone injections, you're coming into the office for like 3 or 4 times for ultrasound evaluations and blood work. The ultrasound evaluations and blood work will tell us how many eggs and follicles you're growing. And you usually get a portal message from us that says, okay, Katie, great job on this cycle. You have 5 eggs in play, 5 follicles. Okay, next appointment, you have 7, you've got 10, you've got 12 in play. Congratulations, take your final dose of medication and a final injection called a trigger shot that loosens the egg in the follicle and allows it to now be captured at the time of the retrieval. Next slide. So the day of your procedure, you typically would come to a Kindbody office and meet a medical doctor anesthesiologist. The anesthesiologist would then give you sedation in the IV. Those of us that have ever had wisdom tooth extraction by IV medication, it's very similar. We typically use a medication called propofol. It puts you into a twilight state, so you're only vaguely aware of what's going on. And then once you're asleep, an ultrasound probe is placed into the vagina, and those ovaries that were previously the size of, let's say, apricots, have now become the sizes of navel oranges, filled with fluid-filled cysts, right? And so those ovaries are sitting right next to your vagina. We're able to place a needle just at the level of your vagina up to those ovaries and drain each one of those cysts, collecting that fluid into test tubes. Next slide. So once that fluid is collected into test tubes, everything is done at our Kindbody sites, right? We store our eggs, our sperm, our embryos all on site, and we have an excellent team of embryologists. I can speak for my embryologists. They're phenomenal. I would trust them with my own eggs. They take these vials of fluid from your ovary containing the eggs back to the lab with them. It's a direct handoff. Our labs, all the kind bodies are essentially built the same, are in back of us as we're getting your eggs, as we're doing your procedure. Our lab, our embryologists, well-seasoned, take those vials of fluid, pour them out onto a petri dish under their microscopes, and can find your eggs. Once they find your eggs, they can select out those mature eggs that they will then freeze, right? Or if you want insemination, we'll get to that a little bit later, but that's the process of egg freezing, as straightforward as that. You would then recover at our kind body in the postoperative area, making sure all your vital signs were stable. Very little risk is associated with this type of procedure. You're usually home within about an hour after your procedure, just kind of groggy from the anesthesia like you would be after a dental procedure. Okay, so if we switch gears for just a moment and go to the IVF portion, how does that differ from what I just described? Everything is the same up until the part where my embryologist looks under her microscope and sees your eggs. Once she identifies those eggs, she puts them to the side for a couple hours. Believe it or not, it's a couple hours. They do just fine. They're warm, body temperature. And we go back to them at that point with a sample of sperm that's provided to us. We then, from that sample of sperm, can pick out, in cases of intracytoplasmic sperm injection or ICSI, the perfect sperm, right? The one that's moving the best shaped. We take that sperm and we can directly inject it into the egg, right? Assuring the fertilization. And that is the process of ICSI and fertilization of that mature egg. The following day, we would have a fertilized egg, is what we hope. And we check on the growth of that egg becoming an embryo again. If that day is day 1, we'll check again on day 5, day 6, and day 7 to see which of those fertilized eggs have become embryos. Next slide. So a nice feature about once we've created embryos is that genetic testing can be performed on it. And this genetic testing can be a screening for gender. It can also screen for genetic disorders such as cystic fibrosis, Down syndrome. We can even screen for known family disorders that you have, Huntington's disease, for example, right? We have that possibility. It's a great feature. I love the idea of the third-party reproduction. It has been so useful for my friends and family. Again, with the use of whether or not we're acquiring donor sperm or donor eggs, whether we're using a gestational carrier, we can do a combination of plans, right? I've done everything from donor egg, donor sperm together to create an embryo, to using that embryo in a gestational carrier, to doing various permutations of that. Again, it just depends on how you envision growing your family and what your needs are. Next slide. Okay, so selecting a donor, of course, there's agency sperm donor. So these are the different options we would have. So little known fact, this was a nice point that I had with a cousin recently, that to acquire a sperm donor, you can use a known donor or you can use an anonymous donor. With a known donor, there are typically certain requirements that come in hand with screening that donor, an adequate sperm supply for them, screening for infectious diseases, including HIV, hepatitis B, hepatitis C, and syphilis, among a couple other viral disorders that can be transmitted in the sperm. We also want to get them to typically sign a legal contract with you if they're known. We also want to have them have psychological clearances if they're known. Right? Those are among some of the things that we screen for in known donors to make sure that you have the easiest transition possible with that family growth. In cases where we use an agency, kind of all that red tape is gone, and these donors have already been made anonymous for you for utilization, and you're simply selecting a donor, typically from profiles, characteristics that you like, and using that sperm for yourself and the number of vials that are available. Similarly, for the egg donor, again, we could use a known egg donor, and we can also use egg banks as well. Banks are a wonderful resource. Again, you have that ability to peruse through profiles, kind of designating characteristics and features that you're looking for. Fresh versus frozen eggs, you know, once frozen eggs are thawed and they're thawed successfully, pregnancy rates between the two are comparable, right? So either option is fine. It just depends on what it is that you're looking for and what it is you want to grow your family. Okay, next slide. Okay, and carrier. This is an excellent option. You can opt to be the carrier yourself of the pregnancy. You can opt to have your partner carry. You can also opt to have a surrogate, and there are different indications for all of these, but we're open to all of them, right? And always have this conversation with your REI as to which one is the best fit for you. Next slide. Okay, so big point, I can't emphasize this enough. There is no cookie cutter plan. And we are each unique in our needs and how our bodies respond. And that is what the purpose of a reproductive endocrinologist is to determine what is going to be the best tailor fit plan for you and what your goal is and how does it get you to your goal the soonest, right? So keeping that in mind, and also with the understanding that we're never going to let you go so far off the trail that this is completely unsuccessful, right? We'll counsel you about that. No, this is not effective. You don't want to do this for these reasons. There's like a 0.2% chance of success, right? I've had those conversations where, this is your plan, but this is how it doesn't add up. Please consider this other path. But that doesn't mean that you don't help to create those plans. Next slide. Okay. So again, just reiterating the different paths that we have as we go through this journey, whether it's insemination, we provide that donor sperm, we do insemination, IVF, whether we need donor eggs or we need donor sperm or we need donor embryos, right? We'll find that way to get those to you. Ovulation induction for those of us that don't get periods. Let's figure out why you don't get periods, and then let's get you pregnant, right? Let's sort through that. And then, of course, we have available egg donors. We can help you with sperm donors. We have gestational carriers for you as well. It's all kind of one-stop shop at Kindbody. Next slide. Okay, the Kindbody 360. So this is that part for the mental health portion of our journey that we want you to understand that we also offer, appreciate, and want to nurture good mental health for you. 90% of us that struggle with infertility also have depression. It is not uncommon, right? And depression takes many forms and can be very difficult to recognize, whether it's not just wanting to be with our same group of friends anymore, not wanting to engage in our same activities, having difficulty sleeping, being anxious. All of these are factors that can go along in our fertility journey, and it's stressful. And we need to recognize that, and we need to seek out kind of that extra bit of help that we need to make this journey not painful for us. It doesn't have to be painful. Next slide. So we have professional support. We have licensed therapists, right, that can do virtual visits with you to start, right? And we have connections in the community to help guide you for another therapist if you want something in person. That's also something to consider. But please, please, please don't leave out that mental health component. Next slide. Okay, so the idea of Kindbody 360 is that we have that holistic view. I can't emphasize that enough. The holistic view where we talk about the therapist, your mental health component, as well as how we reach your goal, and also making you understand, or helping you understand, I should say, that it's okay if this journey has a lot of twists and turns to it, and it's not as straightforward as some of those journeys you may have read about online. That's still okay. This is your own personalized journey. Next slide. And as always, what I've appreciated about kind of social media and where we are now today as a society, where I didn't see this before. I mean, this was just not the case a decade ago or even 2 decades ago, that we're normalizing this conversation around kind of not only our emotional health, but our concerns about our reproductive health, and having these open-ended conversations. Just, hey, this is what worries me. Hey, this is what's going on with my life. Hey, I'm still okay. And it's fine that I'm right now going through this journey and that I need your support. And having that with loved ones, that conversation. And we want to be able to kind of bring this environment to you at any Kindbody location. You'll find that in our Minneapolis office, a lot of us there have struggled with our own fertility journeys. I found that pretty frequently in Kindbody locations, or just anybody that works at a fertility clinic. I've noticed that many of us are drawn to it because we suffered from it at one point in time, back when the conversation wasn't so easy, and many of us were just silently carrying it. Next slide. So your next steps. If you're interested in getting pregnant today, tomorrow, or in the next 5 years, either way, if you came to this webinar, it tells me that you have some degree of interest in finding out more about your fertility. And I don't think it should stop with just this webinar. I think you should get as much knowledge about your specific fertility status as possible and what your fertility goals will look like, to just create a plan for yourself, right? For what this looks like for you in a couple years or next month, right? It's never too soon to do that, and kind of establish that with us as soon as possible. We are extremely open to it. Next slide. So we've got lots of locations. This was my favorite part about asking everybody, where are you from? Where are you? Unfortunately, we do not have an office in Jamaica. The minute we open that, I will completely rotate to that office. But we do have quite a few offices in the name states from before, including Illinois. We had a shout out from New York. We've got California here. We've got, let's see, Texas, we've got Colorado. There are quite a few states. Wisconsin's featured over here. So I think we can represent you at a Kindbody location. And keep in mind also, we offer virtual visits. Our physicians have licenses throughout the United States where we can see you virtually, and you can receive your egg retrieval quite easily outside states. I personally have had patients that I've managed out of state, and that can fly in for just a day to do their egg retrieval, then go home and continue their monitoring from home, from where they came, and then just fly in for procedures. It's usually just one day. Many of our Kindbody locations have local hotels located around them. This is becoming more and more of a common thing for fertility clinics, where patients fly in for their care and then they fly back and do monitoring from afar. Not uncommon. Next slide. Okay, so getting started, you can visit kindbody.com to start a virtual visit. That virtual visit can be scheduled anytime, or it could be in person at your local Kindbody location. I personally find that the virtual visits in this time where we've all become virtual have been so convenient, even for my own healthcare. I think it's been very convenient. So I urge you to utilize that and kind of experience the joys of it. You'll want to go ahead and create your very own Kindbody account to give you access to the portal. The portal is how we can communicate with you. We can schedule visits seamlessly while you're at work or while you're in your own video meeting at work. You can schedule that very quickly. You'll also be able to have access to your lab results. I think one of my favorite features of having a portal type option is that I don't have to worry about necessarily getting all of my health records if I'm going somewhere else to say, oh, I had this blood work done already. I can just have it right there on my phone. It's very convenient for me. We'll confirm eligibility. We'll give you an access code and a unique ID when you create that account, just to make it secure. We also do take insurance at Kindbody locations for fertility management. It's important to check at every Kindbody location what insurers we will take. Some of the newer clinics are in the process of still adding on insurance carriers to their benefit plans. We also cater to a number of employers where you may have a built-in fertility plan. We have financial coordinators that can help sort that out at your first appointment. They'll figure out if you have any fertility coverage, what this looks like for your employers. Some people have several cycles of IVF already covered or medications covered. So it's important to sort that out at your first appointment with us. We'll figure it out with you. You don't have to worry about doing that by yourself. Okay. I think that's my last slide. Questions and answers. Let's do it.
All right. Wow. This is a fantastic group. We do have quite a few questions. And if Dr. Balmir can't get to them, please feel free to give us, drop us a DM on Instagram, or you could also email navigator@kindbody.com. So if she doesn't get to your particular question, feel free to reach out and we will absolutely answer them. So Dr. Balmir, I will, run through these and
Sure.
I'll just start at the top. So one person, Tiffany asked, has Kindbody had any successful patients over 46 use their own eggs?
Yes, our Kindbody location has had successful patients. We have specific locations that have. Just from a statistical standpoint, we know that probability is much lower for our age group, but it is possible depending on AMH levels, depending on antral follicle count. That's a really specific question that really needs to delve into that family history to see possibilities, right? So I would not rule that out as no way, don't worry, this isn't going to work. I'd say it definitely requires a consult to discuss that.
Okay, great. Let's see. We have a question about how does having low levels of DHEA play a factor into fertility, and what does treatment look like in the future?
So as far as low DHEA, we typically don't measure DHEA. More commonly measured is DHEAS. This is an androgen or male type hormone that typically is secreted from the adrenal glands, whereas DHEA is not. The significance of DHEA is somewhat limited in its understanding. DHEAS can be found to be elevated in cases of polycystic ovarian syndrome or certain adrenal gland disorders, whether it's tumor on the adrenal gland or not. So I'd caution with the interpretation of DHEA levels, as it's not standardly measured. I know that there's supplementation with DHEA that some patients do take on that's more considered experimental, potentially for improving egg quality, maybe. So I'd sooner tell patients, if it's elevated, I'm more concerned. If it's low, less of a concern. Definitely something that you may want to consider seeing a medical endocrinologist with if it's coupled with other symptoms and if this is in a person who identifies as male.
Okay, great. We have a question that you actually touched on about nutrition. So you did answer that in your presentation. We also have a question about a price range for surrogacy. And I'm guessing that's something we should probably have them reach out to.
Yeah, they can reach out for the surrogacy question because I have actually some employers that cover that.
Oh, yeah.
Don't know it unless we kind of delve into that. So it can be specific, but I've seen employers cover it. I've seen it be all out of pocket too. And it can vary depending on who the gestational carrier is and the contract that's made between the patient and that gestational carrier.
Yeah, great question. This is a great question. What's the possibility of getting pregnant at 35 plus? Is there hope?
There's always hope. Mm-hmm. There's always hope. I have to leave with that, right? And the hope is dependent on multiple fertility factors, such as, do we know if your tubes are open? Do we know what our egg reserve is? Do we know what the sperm looks like? Answering those questions first will help predict a probability. On average, at age 35, about a third of the embryos that we have or create would be genetically balanced, about a third of them. So no hope is lost. If this is a question that you have, it kind of goes back to that original point, which was get your fertility evaluation. Don't wonder about it. We actually have answers. We can give you direct answers about it and give you direct statistics as they pertain to what we know about your fertility status.
Yeah, great. This may have a similar response about needing that consult, but will an anteverted uterus be an issue for conceiving?
Not at all. I personally have a retroverted uterus. It does fine too. So we're not so much worried about the version or which way the uterus tilts. So what that means for those of us who are wondering what's the anteverted, which retroverted, it's just which way the uterus is going. So the top of the uterus can either tilt towards the back of your body, like towards your back, towards your coccyx, or it can tilt towards the front, like towards your navel. And either rotation is fine. For pregnancy, no direct association with like miscarriage risk or not getting pregnant. It can make for sometimes more complex catheter placement if you're doing an insemination, for example, and you want to drop off the sperm inside the uterus. We use ultrasound guidance at our Kindbody offices. We have that ability to look and see where the catheter is going and which way to follow the canal of your uterus for those specific types of inseminations. And so many of us have dealt with very challenging cases, but it's totally doable.
Great. How about women with diabetes?
That's a big one, right? Diabetes plagues my family as well. So for diabetes, it's important to note a number of factors. We want an up-to-date hemoglobin A1C. We do have recommendations regarding where we want to see the hemoglobin A1C for safe pregnancy for you, right? Really elevated levels of hemoglobin A1C can increase our risk for abnormalities to our baby, miscarriage risk, increase our risk in pregnancy for not only that fulminant diabetes, but your baby can pass away in utero if your blood sugars are uncontrolled. We can also have that risk for preeclampsia, like severe symptoms in pregnancy, right? These are just a few of the things to note with diabetes, but you can still conceive with diabetes. You can still have a healthy pregnancy with diabetes. What matters is understanding where you stand first and foremost in terms of your hemoglobin A1C and being closely followed by an obstetrician who specializes in high-risk obstetrics, and being closely followed by your OB who will manage you also. Diet maintenance, watching how many sugars we're taking in, carbohydrates, it's going to be critical for us in that pregnancy. And as it pertains to our fertility, right, it depends. Usually when we see diabetes, we also see coupled with it issues with our weight, right? Where we'll want to assess that. First thing is to manage that blood sugar and then assess where our weight is. I generally don't have an upper limit for my BMI at which I'll talk to patients or counsel. I don't have that upper limit. We always have conversations about what our goals are. But as long as, you know, the diabetes is well managed, right? This shouldn't be an issue for us being able to pursue IVF, inseminations, or pregnancy. It just matters if it's well controlled.
Got it. Someone is wondering if there's a goal or a magic number of embryos that we're aiming for with IVF or egg freezing.
Age dependent, always age dependent, right? As we get older, we need more embryos and more eggs in order to have one successful pregnancy. So I don't have a specific magic number. It would depend on our age, right? I can quote, you know, you need more eggs than embryos typically to get pregnant, because eggs, when they're frozen, you'll lose a certain amount of eggs to thawing them, and not all of those eggs will fertilize, and not all of those fertilized eggs will lead to embryos. And so we actually use a special calculator that anybody can access. Actually, we have the calculator, I think, available on your portal if you sign up for a Kindbody account, where you can put in a certain number of eggs that you would get at your age, because the portal will compute that for you, and what the percentage chance is for you to have a live birth with it. So again, depending on a number of factors, especially with embryos, it's also dependent on those factors. Age is that factor.
Got it. This is a very specific question. Is there a contraindication for the shoots, artificial insemination shoots? This person did their first try in October 2022 and planning to do a second try next month.
So no contraindication to artificial insemination or intrauterine insemination that would be outside that of pregnancy, right? So if you have a pregnancy contraindication, so for example, let's say you have a known genetic disorder that's associated with a high risk of death in pregnancy or thereafter a pregnancy, that could be considered a relative contraindication to pregnancy, and you shouldn't pursue insemination for that reason. Let's say you had a specific complication in your last pregnancy and your high-risk obstetrician has said, I don't recommend you try this again. It could risk your life. Then that would be a contraindication to intrauterine insemination. But intrauterine insemination is available for all persons with a uterus that have an egg available in the fallopian tube, for the most part.
Okay. Can you do genetic testing right after eggs are retrieved prior to freezing?
Great question. So genetic testing can only take place after embryos are created. The reason is an egg is one cell. An embryo is hundreds of cells surrounded by a membrane. If you genetically test an egg, you would destroy that egg. It's only one cell. But an embryo with hundreds of cells, you could do a biopsy of 5 or 6 cells, freeze that embryo, save for use for later, test those 5 or 6 cells, and like rendering them like not usable anymore, but get information from the DNA there that could give you information about the embryo. So unfortunately, the technology is not there where we can test the eggs. We can only test the embryos. You have to have an embryo created for us to perform that genetic testing.
Okay. This is a good one. Are pulse assessments for women only, or can they be used for evaluating males' fertility too?
So that's a great question. As far as I know, the pulse are for persons with a uterus and ovary, at least one ovary or at least a uterus. I don't know. We have something similar where we do male evaluations, where we offer for you male assessments with a visit with a urologist, a semen analysis, kind of just a history taking initial intake, and then you can have follow-up with our Kind Man group. That's the associated partner group with Kind Body is Kind Man. So we do offer that. If you're someone who's interested in a male assessment, we have that. We have it. We'll get that done for you. So please contact us.
Yes. Does having only one ovary seriously affect how many eggs are produced?
So having one ovary may slightly shorten your time to menopause. It doesn't affect how many eggs you produce, let's say, per month. A normal ovulating woman, you'll just continue to ovulate from that ovary, 1 egg every month you'll release, right? That should still happen. Having one ovary, and if you're interested in conceiving and you have one ovary, I would tell you to consider talking to a reproductive endocrinologist sooner rather than later and formulating that plan. Still very much possible for you to conceive on your own. But with one ovary, we definitely want to check the status of both fallopian tubes and cavity. We want to check what your egg reserve is, because we've lost half of that reserve by losing the other side, right? So we're really dependent on that one ovary to produce everything we need. So that's going to be important. So I would tell you, if you have one ovary, that is an indication, go ahead and see a reproductive endocrinologist.
Yes. With the family history of fertility issues, at what point do you suggest having fertility testing done? We have been trying for going on 6 months, and I want to get testing done. I'm 29.
So with family history of fertility issues, I would tell you, again, this is one of those things. If you think you should see a reproductive endocrinologist, just see them, make the appointment. I tell you to do it sooner rather than later, schedule it tomorrow, right? And the reason for this is you just don't know. There's so much more that we need to find out about what exactly is in this family history. Is there something we need to screen you for sooner? I've had cases with patients where we've done genetic screening and found that there's a genetic disorder that's carried on. It's called autosomal dominant. It's in every 50% chance of inheriting it for every generation, for every child you have, 50% chance. And that family and that person did not want that to continue in their family line anymore. And because we tested them early, this testing can sometimes take months to perform, and then months to get through the IVF cycle as we create specific probes that can target that specific genetic material in the embryo and rule out which embryos we can use and not use to carry on that genetic line. So there are a lot of questions that need to be answered here that are going to be time consuming. So earlier rather than later for genetic questions, and possibly carrying something on from the family or fertility issues that we're carrying on from the family, I'd say right off the bat, make that appointment.
Excellent. What is the success rate after 3 failed IUIs with Clomid, letrozole, and a trigger shot?
Okay. So success rate after 3 failed IUIs after Clomid, letrozole, and a trigger shot?
Correct.
So that depends on our age. It depends on what age that we had this done. It depends on what the IUI specimen had. So, was this an IUI specimen that was normal? Did we have a low sperm count each time? How many eggs were you producing at the time of when you had the trigger shot or ovulation? Those are important factors. But what the bigger picture is when I hear a story like that is you've tried this 3 times. You haven't been successful. At 3 times, we typically will have automatic appointments with patients where we're thinking about how will we pivot in this moment? This plan is no longer helping us achieve our goal. We're not maximizing our chances of success here. We need to consider switching. This sounds like an indication for switching to IVF, which many of us would do already. The indication being like that next step, if you're producing an adequate amount of eggs, you have enough sperm and we're still not being successful after 3 cycles, it's now time to move on to IVF. The chances are not going to significantly increase with more cycles of the same.
Okay, great. I know you did touch on PCOS, or I believe you did. I know this is a common topic. Somebody's asking, what if you're 30 and you have PCOS?
So if you're 30 and you have PCOS and you're looking to conceive, then I would tell you again, don't delay in having that fertility appointment, because oftentimes with PCOS, we have no menses or few cycles, and we can't tell when exactly we're ovulating. So we're already operating in a bit of a handicap. And with that handicap, you need kind of a leg up. And what we can provide as an REI are medications to help bring about that ovulation. So now you have a regular release of eggs to be exposed to sperm. But I think also in those assessments, I think it's important to also look at all the big picture of the fertility. Now I start evaluating for fallopian tube patency. I'll also evaluate to make sure that the sperm look okay, so that when that egg is released, we're reassured that the one thing that was holding us back was only the fact that there was not egg release and no other factors were stopping us from conceiving.
Got it. We have so many questions, Dr. Baumeier. This is just wonderful. I'm probably going to have to just stop after this next one. But again, I ask everybody to email us with these questions that we didn't get a chance to get to. This is an amazing group. I'm going to go with Sarah here. I'm 42 and have seen an OBGYN, and my egg reserve count is low, only 15%, and have tried to get pregnant for the last 3 months. I haven't been successful. What are my next options?
Oh my goodness. So this question hits really close to home. You are all of us. So with a low egg reserve and at age 42, the truth is the chances of having a genetic child are very low. The lower the egg reserve, the fewer kind of genetically balanced eggs we have, but that doesn't close the door on our ability to conceive. It doesn't close the door on our ability to expand our families. And I also say this with the idea that anything is possible. I think all of us have heard that one story from our family member that got pregnant and thought they were actually in menopause, but they were actually pregnant and they were well into their 40s. I think at least I know one person everybody has heard that story at least once. I would say that's the exception and it's not the rule. And at 42, with a low egg reserve and prior failed cycles, we now start to think about, pivoting. I use pivot a lot, right? Because I've had to engage it in my own life. And we start thinking about, what about this option for donor egg? This goes in hand again with the idea that you can expand your family, just be open to all the ways we can do it. And we can do this in multiple ways. And here comes the question of, should we start to utilize donor egg at this point, right? Where the pregnancy rates for donor egg are significantly higher. The live birth rates for donor egg are significantly higher than those of using our own egg in an IVF cycle. So upwards of 50% in using a donor egg. And this is of course contingent on other factors such as your uterine status. At this point, I would say, have this conversation with your REI or have this conversation with me. And let's talk about what our other options are if we've kind of exhausted all of the options of utilizing our own eggs and ovary.
Okay, great. So that was just wonderful. Thank you, Dr. Baumeier. I know that you're probably getting a sore throat from.
I forgot to bring it up with me. I don't know.
Yes, I know you. This is something you're so passionate about, and I just love listening. I just want to let everyone know that after this is completed, there is going to be a survey. So feel free to fill it out and let us know if you're interested in starting treatment. It's just a quick way of getting in and seeing one of our wonderful REIs like Dr. Baumeier. So we hope to see or hear from you. Dr. Baumeier, you can wrap it up.
Thank you, everybody, for joining us tonight. You could have spent your evening a dozen other ways, but you chose to spend it with us and listening to me prattle on about the things I'm most passionate about. So thank you. Please feel free to reach out anytime. I'm happy to discuss any of your ideas, plans, cycle ideas anytime. Thank you, everyone. Have a great night.
Thank you.